Hello everyone, good evening. I am Dr. Puneet and today I will talk about management portion of acute ischemic stroke. This is very important topic, at least for clinicians, for medical practitioners. So I will talk, though I will talk in brief, but I will talk each and every part, this management portion. I will start from the basics and then move to the very advanced treatment which is available. So, firstly, once a patient comes to emergency ward with acute onset weakness of one half the body or slurred speech or field defect, and if the duration is less than 3 hours, then you should be or up to 4.5 hours, then you should be very quick. Very quick means uh, the clinical assessment should be done very quickly, and patient BP should be checked immediately, sugar should be checked, ask for any focal twitch or focal seizures to confirm about stroke mimickers, and then send patient for urgent CT. Suppose CT is normal, means it doesn't source any bleed. It means patient is having ischemic severe. And once you manage ABC, airway, breathing, circulation, then first step is reperfusion strategy. If your patient is in window, if he is up to 4.5 hour, best is 3 hour, but up to 4.5 hour you can give thrombolysis option to your patient. So what are the important point in this thrombolysis? If patient presented to you in window, means the time to the ictus, to the onset of symptoms is within 3 hours, it is very good. If it is up to 4.5 hour, then you can thrombolyze, but the results are not so good as in window of 3 hours. So you explain all the things to your patient's attendant that I am going to give a drug which will remove the plaque and the blood flow will be restabilized. But while giving this drug, uh, when this blood flow restabilize, it may sometime lead to leakage of blood, and a patient might get converted into the hemorrhagic stroke, hemorrhagic transformation. Though it is rare, but it may occur. And if attendants are willing, then proceed. The important history for exclusion is any major surgery within 2 weeks, any GI or genitourinary bleeds within 3 weeks, any arterial punctures within 7 days, or prior head injury is there, or prior intracerebral hemorrhages is there. So these are the exclusion. If it is not there, then thrombolyze your patient with either actylase. Two drugs are available which we neurologists regularly use. One is actylase and second is tenecteplase. Actylase is given 0.9 mg per kg, maximum 90 mg, and 10% IV bolus. And the second drug is tenecteplase. Tenecteplase 0.25 mg per kg, maximum 25 mg, and it is the whole drug is given in bolus, this tenecteplase. So the important thing is this, that tenecteplase is much safer. I thrombolize hundreds of patients with tenecteplase, and there is hardly any case I'm not been able to remember that in any patient get converted into the hemorrhagic stroke. So the reperfusion is very good, and the risk of hemorrhage is also very less with tenecteplase, though it is for more with actylase. So first thing is reperfusion therapy. So when you reperfuse the patient, it is very good. Or suppose a patient comes out of window, he comes to 6 hours. So some in some intervention centers, they can do mechanical thrombectomy. Mechanical thrombectomy with the help of Mercy clot retrieval catheter. They go and remove the clot. Sometimes they also use tenecteplase or ectalase prior to this procedure. And there are various studies. One studies, MR clean studies done in Netherlands, or extended IA studies. There are several studies done for mechanical thrombectomy, and they says that mechanical thrombectomy is a very good option in a patient who is out of window of 3 to 4.5 hour. Okay. Then after this, the second step is cytoprotective or neuroprotective agents. Neuroprotective or cytoprotective agents, uh, actually once there is a blockage or there is any blockage, then there is decreased flow to that area. So if you increases collaterals, that will help penumbric portion to survive. So this collateral can be increased with the help of statins. High dose statins are used as a neuroprotector. Although some studies says that it may lead to the hemorrhagic conversions, but it is not very true. Um, so you can use high dose statins, uh, to increase collaterals. Some you can also, as this decreased flow lead to the increased excitatory amino acid, so excitatory amino acid antagonist may be given. And that will lead to increased intracellular calcium. So calcium channel blocker like nimodipine, some trials are also there. So there is more than 120 trials, but no one is showing very promising effect of this neuroprotective drugs. And then this increase leads to calpain enzyme activation, and that lead to the rapid necrosis, rapid apoptosis, rapid cell death. So blocker of this is also available. And then free radicals, increased number of free radicals is there. Then so free radical trapping agents such as serovive. So there are various studies, more than 120 studies about this neuroprotective drugs are going, but no one is very satisfactory. You should also remember one thing, that whenever you thrombolize, aspirin should be given after 36 hours. Well, it should not be given immediately, because some center prefer after 24 hours, some gives after 36 hours. I personally recommend after 36 hours because of increased risk of hemorrhagic transformation if you give aspirin early. Okay. So this point I want to mention here. If you are thrombolizing your patient, then delay while giving aspirin to up to 36 hours, because patient might bleed. Okay. Then so first step is reperfusion. Second strategy is cyto or neuroprotective agents, and third is preventing or treating complications. So complications, once a patient come to you, so first thing is maintain his blood pressure. BP, the optimal BP is between systolic BP is between 160 to 200, and the diastolic BP is between 70 to 110. Until unless patient undergoing for this thrombolysis, because for thrombolysis systolic the BP criteria is 185/110. Okay. So and for immediate control you can use IV labetalol, but this Nicardia or nifedipine immediate release formulation dipin, this must not be given because it increases infarct size because of decreased flow to the penumbric regions. Okay. And then patient, 1/3 patient of brainstem stroke and 1/10 patients of this 1/10 patients of this hemispheric stroke may have some dysphagia component, and aspiration, chances of aspirations might be there. So you can prevent it with the help of head in elevation, and if you think that patient might may aspirate, then put nasogastric tube to the patient. And then important complication is brain edema, cerebral edema. It start within hours and peak in 3 to 5 days. So first week complication, major complication is brain edema, and everyone must address this complication. Prevention of this complication is because if brain get herniated because of this edema, patient will die. Okay, so give IV mannitol, 3% saline, head in elevation, if needed hyperventilation, if needed hemicraniectomy for posterior fossa or posterior circulation infarct, sometime posterior fossa decompression will be done. Okay, so this then aspiration, as I already says, 2nd to 4th week major complication is aspiration. If seizure occur, then then give anti-seizure medicine, DVT prophylaxis with the help of Clexane, 40 mg subcute injection is given. Bed sore prevention, urosepsis, so if possible avoid catheter, Foley's catheter, male catheter might be used. Okay, then after all this, how will you prevent further stroke? So for prevention of further stroke, the mainstay of treatment is number one, vascular decreases or control vascular risk factors such as diabetes management, BP management, quit smoking. This is very important. And then cholesterol lowering drugs, statins must be given. And then important thing is antiplatelet drugs. This antiplatelet drugs, aspirin is commonly used, but aspirin, its anti-aggregatory effect start within an hour, and its antifibrinolytic effect persists up to 4 hours. When you take it, its antifibrinolytic effect persists up to 4 hours, and anti-aggregatory effect is started within an hour. So it is very effective drug for secondary prevention, not for primary. Primary prevention, it can be used in older female in low dose every other day. If your patient is not experienced stroke in his past, so there is no need to give daily aspirin. Give it alternate day treatment, 75 mg every other day as a primary prophylaxis, not for secondary. Secondary prophylaxis, use 150 mg ecosprin or aspirin. And remember one more thing, some trial, especially Capri trial, suggests that clopidogrel is better than aspirin. Some trial suggests that combination is better than monotherapy, especially this some point study and this chance study and this cure study. This is that combination is better, but as per chance studies, short term dual antiplatelet is should be given for 3 weeks only, and then after that you should use single antiplatelet drugs because of risk of hemorrhage, because of risk of GI bleed or intracranial or extracranial bleed. Chances of intracranial or extracranial bleed is there, so dual antiplatelet should be used for short term, and then patient should be shifted in single antiplatelet. Some studies shows 3 months course of dual antiplatelets. So, but most of the studies recommend only 3 weeks of dual antiplatelets and then monotherapy. Some new drugs, especially P2Y12 antagonist, this ticagrelor, ticastroius, marketed with the name of Ticastro or ticastroius, as a it is superior than clopidogrel even, and it might have good future in stroke patients. But up to now, we routinely use this clopidogrel and aspirin in our patient. Some other drugs such as dipyridamole, celestazole, these are also antiplatelet drugs which are used. Now, suppose if your patient is along with stroke having cardiac arrhythmias such as AF, then anticoagulant, warfarin, is very important. So this an oral anticoagulant is given if a stroke patient is also having arrhythmias, AF, or there is a MI, to prevent a stroke in patient with concomitant MI. So this is these are used. So in cardiac arrhythmia patients, you have to use this warfarin. Warfarin plus aspirin is not superior to warfarin alone. So there is no need to combine warfarin with aspirin. Okay, and then this novel oral anticoagulants, factor 10 inhibitors, this rivaroxaban or this apixaban, or this dabigatran, they may also be used in place of this warfarin with good effect, good result. Okay. So this is all about prevention. Now suppose patient of a stroke, when you do carotid Doppler, you find carotid artery stenosis is there. Then surgical treatment also comes in place. Okay, for prevention of further stroke. In symptomatic carotid artery stenosis, means your patient is having TIA or minor stroke with 70 to 99% of blockage of this carotid artery. Then carotid endarterectomy should be done in the patient. One North American trial, NESET trial, and this European carotid surgery trial, ICAS trial. These two trials support carotid endarterectomy in patient with symptomatic carotid artery stenosis. Now suppose if complete occlusion is there, then endarterectomy option get lost. There is no option of endarterectomy, so then bypass, intracranial extracranial bypass surgeries may be done, but that is again not very promising. The results are not very good. Then one more thing which you can do is carotid artery stenting. One North American trial shows that stenting is better in younger patient, while carotid endarterectomy is better in older patient. Although stenting is inferior to carotid endarterectomy, as stated by two European trials, EVAS 3 years and one more, and that endarterectomy is better than, but in younger patient you can go with stenting, and older this endarterectomy may be considered. Now in asymptomatic carotid artery stenosis, there is no need for any surgery. Just treat your patient medically. Although one European studies suggests that if there is more than 80% blockage, then surgical treatment is better than this medical treatment in asymptomatic. And although the complication risk is also lower in asymptomatic patient, but what I do in my patient, I never prefer this carotid endarterectomy surgery in asymptomatic. Incidentally, if I find this carotid artery stenosis incidentally, I'll never plan for endarterectomy surgery. I always give them statins and stabilize their plugs only. So in this way, you can treat your patient with acute ischemic stroke, and that's all. And from the next session, I will talk about brain hemorrhage. Okay. Good evening again. Thank you for listening me.